Alright, let's talk about something incredibly important, but often overlooked in our bloodstream. We all know about red blood cells carrying oxygen and white blood cells fighting off infections. But there's a third major player in the game, a tiny but mighty component that literally saves our lives every single day. I'm talking about platelets, or thrombocytes, as they're known in the more formal medical textbooks. These aren't even complete cells. They're small, irregular-shaped fragments that break off from massive cells in your bone marrow called megakaryocytes. Think of them as the emergency response team of your circulatory system, always on patrol and ready to spring into action at a moment's notice. These little guys are absolutely crucial for a process called hemostasis, which is just a fancy way of saying stopping bleeding. Imagine you get a small cut, maybe while you're cooking or shaving. Without platelets, even a minor nick could become a serious problem. They are the first on the scene, plugging the hole and kicking off a complex cascade of events that leads to the formation of a stable blood clot. Their role is so fundamental that a low platelet count, a condition known as thrombocytopenia, can lead to dangerous, uncontrolled bleeding. Understanding how they work is not just academic, it's a core concept for any aspiring medical or nursing professional. So what makes these cell fragments so effective at their job? It all comes down to a few key properties. They have this remarkable ability to change their behavior instantly when they detect damage to a blood vessel. They can stick to things they normally wouldn't. They can stick to each other, and sometimes they can be made to stick together by other factors in the blood. These three distinct yet related phenomena are adhesiveness, aggregation, and agglutination. Grasping the difference between these three A's is fundamental. It's the key to understanding everything from basic wound healing to complex bleeding disorders and the effects of certain medications. In this discussion, we're going to break down each of these properties one by one. We'll explore exactly what they mean, how they happen, and why the distinction is so important in a clinical setting. Forget the dense, confusing jargon you might find in some textbooks. We're going to use simple language and clear examples to make sure you walk away with a solid, practical understanding. By the end of this, you'll be able to confidently explain these concepts to your peers, your tutors, and one day, even your patients. So let's get into it and start unlocking the secrets of these incredible little lifesavers. Let's begin with the very first step in the process of stopping a bleed: adhesiveness. In simple terms, platelet adhesiveness is the ability of platelets to stick to a non-platelet surface. This is the crucial initial action that happens the instant a blood vessel is damaged. Under normal circumstances, your blood vessels are lined with a super smooth layer of cells called the endothelium. This layer is like a non-stick coating, preventing platelets and other blood components from latching on as they flow by. It's a perfect system designed to keep blood flowing freely without any unwanted clots forming inside your healthy vessels. However, when you get a cut or an injury, this smooth endothelial lining is breached. This breach exposes the underlying structures of the blood vessel wall, most importantly a protein called collagen. Think of this exposed collagen as a bright red flag, a distress signal that only platelets can see. When platelets, which are constantly circulating in your bloodstream, come into contact with this exposed collagen, their adhesive property is activated. They immediately stick to the site of injury. This isn't a random clumping, it's a specific, targeted response. The platelet essentially acts as the first patch on the leak, initiating the entire repair process. This initial sticking action is incredibly important because it localizes the response directly to the site of damage. The body doesn't want clots forming all over the place, just where they are needed. Platelet adhesiveness ensures that the hemostatic plug begins to form exactly at the point of the vessel wall breach and nowhere else. This property is mediated by specific receptors on the platelet surface that recognize and bind to proteins like collagen. One of the most critical players in this process is a protein called the von Willebrand factor, or VWF, which acts like a molecular bridge, helping the platelet to adhere firmly to the exposed collagen under the high-pressure flow of blood. So, to put it all together, adhesiveness is the foundational step. It's the platelet's ability to recognize and stick to the damaged part of a blood vessel wall. It's the alarm bell and the first responder all in one. Without this initial adhesive step, the subsequent stages of clot formation simply cannot happen. Any defect in platelet adhesiveness, whether due to a genetic disorder or medication, can lead to a significant bleeding problem because the body loses its ability to form that initial crucial plug at the site of an injury. It's the first domino to fall in the cascade of hemostasis. Let's dive a bit deeper into the mechanics of how platelet adhesion actually occurs, because the details are what separate the good students from the great ones. When a blood vessel wall is injured, the subendothelial matrix, which is rich in collagen fibers, is exposed to the flowing blood. This is step 1, the injury. The blood itself contains a crucial protein we mentioned earlier, the von Willebrand factor. This factor is released by both the damaged endothelial cells and the platelets themselves. It immediately binds to the exposed collagen at the site of the injury, essentially coating the damaged area and preparing it for the platelets. Now here come the platelets, flowing past in the bloodstream. On the surface of every platelet is a specific receptor, a glycoprotein known as GP-IB. This GP-IB receptor has a special affinity for the von Willebrand factor. As a platelet tumbles past the injury site, its GP-IB receptor latches onto the VWF that is already bound to the collagen. This connection acts like a tether, slowing the fast-moving platelet down and allowing it to firmly attach to the vessel wall. This initial tethering is vital, especially in arteries where blood flow is rapid and forceful. Without VWF acting as this molecular glue, platelets would simply be swept away by the current. Once the platelet is tethered via the GP-IB-VWF bridge, it's not done yet. This initial binding triggers a change within the platelet itself. It becomes activated. This activation causes other receptors on the platelet surface, specifically GP-IAI and GP-6, to bind directly to the exposed collagen fibers. This creates multiple stronger points of contact, securing the platelet firmly in place. Think of it like a rock climber first throwing a grappling hook to stop their momentum, and then finding solid handholds and footholds to secure their position. This multi-step process ensures a stable and robust adhesion. This entire sequence, injury, VWF binding to collagen, platelet tethering via GP-IB, and then firm attachment via other receptors, is what we define as platelet adhesiveness. It's a highly specific and regulated process that forms the foundation of the primary hemostatic plug. Understanding these individual components, like VWF and the specific glycoprotein receptors, is critical. Deficiencies in any of these elements, such as in von Willebrand disease or Berners-Solier syndrome, which is a GP-IB deficiency, directly impair platelet adhesion and lead to bleeding disorders. This shows just how elegantly and precisely this system is designed to function. Once the first wave of platelets has successfully adhered to the site of injury, the job is far from over. A single layer of platelets is not nearly enough to plug a hole in a blood vessel. This is where the second crucial property comes into play: platelet aggregation. If adhesiveness is about platelets sticking to the damaged vessel wall, then aggregation is all about platelets sticking to each other. It's the process of recruitment, where the initial platelets that have adhered to the injury send out signals to call for backup, attracting more and more platelets to the scene to build a bigger, more substantial plug. This process begins the moment a platelet becomes activated, which, as we discussed, happens upon adhesion. Activation is like flipping a switch inside the platelet. It undergoes a dramatic transformation, changing its shape from a smooth disc to a spiky sphere with long, outstretched arms called pseudopods. This change in shape greatly increases its surface area, allowing it to make contact with more of its neighbors. More importantly, this activation triggers the release of chemical messengers stored within tiny granules inside the platelet. These chemicals are the signal flares that call other platelets to join the party. The key chemical signals released by activated platelets include adenosine diphosphate, or ADP, and thromboxane A2, also known as TXA2. These substances pour out from the initial layer of adhered platelets and into the surrounding blood. When nearby, circulating platelets detect these chemicals, they too become activated. It's a positive feedback loop. Activated platelets release chemicals that activate more platelets, which in turn release more chemicals, leading to a rapid and exponential recruitment of platelets to the site of injury. This is how a small initial response can quickly escalate into the formation of a significant platelet plug. So, in essence, aggregation is the chain reaction that follows adhesion. It's the process by which platelets clump together, forming a multi-layered, three-dimensional mass that physically blocks the hole in the blood vessel. While adhesion is the foundation, aggregation is the process of building the walls of the barricade. This clumping is not random. It is a highly specific process mediated by newly expressed receptors on the activated platelets, which we will explore in more detail next. Understanding aggregation is key to understanding how a stable, effective clot is formed. Let's get into the specifics of how these platelets actually stick to one another during aggregation. It's honestly a fascinating piece of molecular engineering. When a platelet is activated, either by adhering to collagen or by chemical signals like ADP and TXA2, it undergoes that crucial shape change. But, something else happens on its surface that is the absolute key to aggregation. A new receptor, which was previously inactive, becomes functional. This receptor is called glycoprotein IIB-R3 or GPIBR3. On an unactivated resting platelet, this receptor is present but unable to bind to anything. Activation is the key that unlocks its function. Simultaneously, another crucial protein comes into play, fibrinogen. Fibrinogen is a soluble protein that is always present in your blood plasma, just floating around. Under normal circumstances, it doesn't interact with platelets. However, the newly activated GPT3TA receptor has a specific binding site for fibrinogen. So, when platelets become activated, their GPIB3TA receptors are ready to grab onto any fibrinogen they encounter. This is really the central mechanism of aggregation. Fibrinogen acts as the bridge that connects two activated platelets together. Imagine two activated platelets, both with their GPIB3A receptors ready. A single molecule of fibrinogen can bind to the GPIB3A receptor on one platelet and, at the same time, bind to the GPIB3A receptor on a neighboring platelet. This creates a physical link, a fibrinogen bridge, holding the two platelets together. Now, just multiply this by thousands and millions. Each activated platelet can form multiple links with multiple neighbors, creating a vast, interconnected network of platelets, all held together by fibrinogen. This is what forms the bulk of the primary hemostatic plug, the barricade that stops the bleeding. This process is actually a prime target for anti-platelet medications. For example, drugs like abciximab and tirofiban are GPIB3A inhibitors. They work by blocking this receptor, preventing fibrinogen from binding and thus preventing platelets from aggregating. This is incredibly useful in preventing heart attacks and strokes, which are often caused by unwanted clot formation in arteries. By understanding this specific molecular interaction, the GP2OB3A receptor binding to fibrinogen, you understand not only a fundamental physiological process, but also the mechanism of action for some of the most important drugs in cardiology. Now we need to discuss a third term that often gets confused with aggregation agglutination. While both aggregation and agglutination involve platelets clumping together, the underlying cause is completely different. This is a critical distinction to make. Aggregation, as we've established, is an active physiological process. It requires platelet activation, the release of chemicals, and the expression of GP2B/3A receptors to bind fibrinogen. It's the body's normal, healthy response to injury. Agglutination, on the other hand, is typically a passive process, often pathological or induced by external factors, and it does not require platelet activation. Platelet agglutination is the clumping of platelets caused by an external agent, most commonly an antibody or some other factor that physically bridges the platelets together without them needing to be switched on. In this scenario, the platelets are essentially innocent bystanders that are being glued together against their will, so to speak. The most common cause of platelet agglutination in a clinical context is the presence of certain antibodies that bind to the surface of platelets. For example, an antibody might bind to the GP1B receptor on one platelet and also to the GP1B receptor on another, linking them together. Unlike aggregation, This process doesn't involve the release of ADP or thromboxane A2, and it doesn't require fibrinogen to link GP2B/3A receptors. The clumping happens simply because the agglutinating agent, the antibody, acts as the glue. This can happen in certain autoimmune conditions where the body mistakenly produces antibodies against its own platelets. It can also be seen in the lab as a diagnostic tool or, problematically, as an artifact in a blood sample. For instance, some individuals have antibodies that are active only in the presence of the anticoagulant EDTA, which is used in purple-top blood collection tubes, leading to a falsely low platelet count on automated analyzers. Therefore, the key takeaway is the difference in mechanism. Aggregation is an active platelet-driven process initiated by physiological stimuli like collagen exposure. It's a vital part of healing. Agglutination is a passive process where platelets are clumped together by an external factor, like an antibody, without the platelets themselves initiating the process. This is often a sign of a disease state or an in vitro phenomenon. Confusing the two can lead to significant misunderstanding of a patient's condition. While they might look similar under a microscope, a clump of platelets is a clump of platelets. The reason they are clumped is fundamentally different. Let's look at some real-world examples to solidify our understanding of agglutination, as this is where it becomes clinically relevant. One classic example is a condition called thrombotic thrombocytopenic purpura, or TTP. In TTP, there's a deficiency in an enzyme that normally cleaves very large multimers of von Willebrand factor. As a result, these ultra-large VWF multimers circulate in the blood. These large, sticky VWF strings act as an agglutinating agent. They can spontaneously bind to platelets via their GP1B receptors and cause them to clump together in small blood vessels, even without any vessel injury. The platelets are not activated in the traditional sense. They are passively ensnared by these large VWF nets. This widespread agglutination causes two major problems. First, it forms microthrombi, small clots, that can block blood flow to vital organs like the brain, kidneys, and heart, leading to severe organ damage. Second, because so many platelets are being used up in these inappropriate clumps, the number of circulating platelets drops dangerously low. This is the thrombocytopenia part of the name. So, the patient paradoxically has both a clotting problem, inappropriate agglutination, and a bleeding problem, low platelet count. This highlights how agglutination is a pathological process, very different from the controlled, localized aggregation seen in normal wound healing. Another important clinical scenario involves heparin-induced thrombocytopenia, or HIT. Heparin is a common anticoagulant medication used to prevent clots. However, in a small percentage of patients, the body develops an immune response to it. The body forms antibodies that bind to a complex of heparin and a protein on the platelet surface called platelet factor 4. This antibody heparin PF4 complex then acts as a powerful agglutinating and activating agent. The antibody can bridge multiple platelets together, causing them to clump. In this case, it's a bit of a hybrid, as the antibody binding also strongly activates the platelets, leading to a massive prothrombotic state. Again, the result is the same paradox as in TTP: widespread clot formation and a plummeting platelet count. This is a life-threatening complication of heparin therapy. These examples show why it's so vital to distinguish agglutination from physiological aggregation. When a lab report shows platelet clumps, a clinician must ask why they are clumping. Is it part of a normal healing response, or is it due to an abnormal agglutinating factor like an autoantibody or a drug-induced complex? The answer dictates the entire course of treatment, which could range from simple observation to emergency plasma exchange or stopping a critical medication. So let's tie it all together and create a clear, simple summary of these three crucial terms. Think of it as a quick reference guide you can use in your studies. The key to not getting them confused is to focus on two things: what the platelets are sticking to and what is causing them to stick. Getting this right will make you sound sharp and knowledgeable in any clinical discussion. It's the kind of fundamental knowledge that underpins so much of hematology and emergency medicine, so it's worth taking a moment to ensure it's crystal clear in your mind. First, we have adhesion. This is platelet-to-vessel wall interaction. The cause is exposure of subendothelial components, primarily collagen, following an injury to the blood vessel. The key players are the von Willebrand factor and the platelet's GP1B receptor. This is the very first step in forming a clot, the initial patch on the leak. It is an active process that leads to platelet activation. Think adhesion for attachment to the site of injury. It's the scout who finds the breach and plants the first flag. Without this, the cavalry never gets called in. Second, we have aggregation. This is platelet-to-platelet interaction. The cause is platelet activation, which leads to the release of chemical signals, ADP, TXA2, and the conformational change of the GP2B/3A receptor. The key players are the activated GP2B/3A receptor and the fibrinogen molecules that bridge the platelets together. This is the second step, where backup arrives and a substantial plug is built. It's an active physiological process that follows adhesion. Think aggregation for accumulation of platelets to form a mass. This is the team building the barricade. Finally, we have agglutination. This is also a platelet-to-platelet interaction, which is why it's often confused with aggregation. However, the cause is fundamentally different. It is typically a passive process caused by an external factor, like an antibody or abnormal VWF multimers, that physically links the platelets together. It does not require intrinsic platelet activation, though it can sometimes cause it secondarily. It's usually a pathological or in vitro phenomenon. Think agglutination for being glued together by an outside force. This is not part of the normal construction crew. This is an outside event causing a pile-up. We've covered a lot of ground today, breaking down the essential functions of blood platelets into three distinct properties: adhesion, aggregation, and agglutination. Understanding these concepts is not just about memorizing definitions for an exam. It's about building a foundational knowledge of how the body protects itself and what happens when those systems go awry. From a simple paper cut to a complex condition like TTTP or a medication reaction like HIT, these principles are at the heart of the matter. Having a firm grasp of the difference between a platelet sticking to collagen sticking to another platelet via fibrinogen, or being stuck together by an antibody, is what separates a student from a future clinician. As you continue on your path in medicine or nursing, you will encounter these concepts again and again. You'll see them in pharmacology when you study antiplatelet drugs. You'll see them in hematology when you diagnose bleeding and clotting disorders. You'll see them in the emergency department when you're trying to manage a trauma patient. This knowledge is your toolbox, and the more precisely you understand how each tool works, the more effective you will be. Never underestimate the power of mastering the fundamentals. They are the bedrock upon which all your future learning will be built. I know that medical education can be overwhelming. You're constantly bombarded with complex pathways, long drug names, and intimidating terminology. The key is to break it down, just like we did today. Find resources that speak your language and focus on understanding the why behind the what. Don't just memorize that GP2B/3A is for aggregation. Understand that it's the activated receptor that grabs fibrinogen to link platelets, and you'll never forget it. This approach will make learning more engaging, more effective, and a lot less stressful. I hope this discussion has helped clarify the critical roles of platelets and made these topics more accessible for you. If you found this breakdown useful and want to continue building your medical knowledge with clear, engaging, and straightforward content, then I strongly encourage you to explore what we have to offer. For more deep dives into complex medical topics, simplified for students just like you, make sure you check out Joen Academy. We're dedicated to helping you succeed on your journey. Keep up the great work, stay curious, and I'll see you in the next one.